I'm Teresa. I'm one of our psychiatric liaisons. So I'm going to walk us through a little bit on substance use disorders, how we assess and treat those in the acute care setting. So there will be a couple pauses for videos throughout, and then we will have time for some experience and questions and answer at the end. So let's go ahead and hop in. So what are we trying to cover? We are looking at identifying and describing signs and symptoms of substance use disorders, especially in the acute care setting. We were going to take a look at the pathophys of alcohol and opiate intoxication and withdrawal. We'll discuss the CIWA, the COWS, and the PASS. These are our assessment scales that we use most commonly for the treatment, both with intoxication and withdrawal. And we'll analyze current monitoring and management practices for alcohol withdrawal and opiate withdrawal. We'll look at the application of the CIWA assessment scale and best practices using our general adult alcohol withdrawal order set, which is updated with EPIC, yay. And the application of COWS assessment scale and best practices using the opiate symptom withdrawal management, also updated for our EPIC. So that's what we're hoping to cover in the next couple hours here. So when we were putting together the presentation itself, there was a lot of discussion about how we prioritize, how we sort of triage, what are some suggested guidelines around the use disorders in general. And we pulled out two, both alcohol and opiate, that we wanted to focus on up front when we triage, because these are the two potentially that not only cause us some of the most challenges, but potentially have the worst outcomes if we don't control and manage them. Alcohol and benzodiazepine being potentially lethal. So when we're triaging, we want our staff to first kind of look at being concerned about alcohol withdrawal first. So we want to assess and rule that out first, and then move on to opiate, and then we'll move on to the rest of the substance use disorders. So things to be concerned about, things that should be setting off all kinds of red flags for you. If your patient already has current symptoms of alcohol withdrawal, if they came in with a blood alcohol over 200, or a urine drug screen that was positive for benzos, or history of sustained use. So if they've been habituated to a benzodiazepine or alcohol. If there's been prior history of withdrawals, if we know that, or any history of blackouts, or if they've had combined episodes like frequent intoxication. So if any of those are setting off red flags for you, then you think, okay, I need to monitor, which means if I don't have CIWA ordered already, like, let's make sure it gets there. And I want to make sure that I'm thinking ahead of time about treatment for alcohol withdrawal. Because again, this is the one that's potentially the most deadly if we miss it. If we sort of ruled this out, we're not concerned. We also want to make sure we're asking those questions about opiate withdrawal. So if they have current clinical symptoms of opiate withdrawal, if they have a history of chronic opiate use, if they have positive urine drug screens for opiates, oxycodone or fentanyl, or history of chronic use, then we want to be thinking about monitoring and treating. So we want to make sure we get those COWS ordered for the assessment portion, and that we're having those discussions with physicians. Because with both of these, I think it's easier to monitor and to have available the tools, the medications, the things that we might need to treat the withdrawal from. And with, if we have them and we don't need them, okay, great. But if we need them and we don't have them, that becomes potentially very, very problematic. If we've ruled those out and we're looking at other type of substance use disorders, think about other drugs of abuse. So we have stimulants, PCP, hallucinogens, cannabis. They all kind of create their own challenges in terms of monitoring. That's why sometimes if they say, we don't need to order a drug screen because they already admitted to using methamphetamine, we might want to question that and say, it's helpful to know if they've self-reported some kind of use pattern, but we also might want to trust but verify and check, because sometimes people are using multiple things and they may or may not even know what is involved in their drugs. So we want to look at identifying what we think might be a symptom of either an intoxication or withdrawal, continuing to do that screening. And a lot of it comes down to agitation management. So after we're done kind of going through some of the substance use, we're going to talk a little bit about agitation management and what sort of tools, techniques, medications, things like that come up most frequently to help us manage those. So for some of you, this might be a little bit of review if you've had this talk before, but we wanted to highlight again, why are we doing this? Why is it important? Some of it is the prevalence, okay? Because alcohol use in particular in acute care setting is identified as one of the leading causes of preventable death. So this is a biggie. In specific populations in San Diego, like our veterans, they have, when they're admitted to the hospital for medical reasons, they can go as high as 42% experience some kind of alcohol withdrawal symptom, right? In the US, more than 20% of patients admitted to acute care meet criteria for alcohol withdrawal. So if you've heard me talk about it before, you may have heard me say it. We are not great at screening. We can continue to get better at that so that we can recognize and respond appropriately for these folks. And especially even in our elective surgery areas, acute alcohol withdrawal is associated with perioperative complications, 40% higher cost of treatment, 85% higher length of stay, and it makes all of our lives a little bit harder when we don't catch it early on. So who would we screen for substance abuse? I know this is kind of a funny picture, and as your proctors, you might hear the giggles in your class, but when we think about general screening, a lot of us want to rely on just sort of eyeballing. Do they look like they have a problem? Do they look suspicious? Like, should I be concerned just by looking at the person? And that can be problematic for a number of ways. We want to highlight for everyone that implicit bias is a thing, and it's a form of bias that occurs automatically and unintentionally, and nevertheless affects our judgments, decisions, and behaviors. So particularly around the substance use disorders, we found implicit bias can be very, very challenging as it impacts people's opinions on who they should screen or should they be concerned or not. So it's not about we don't have bias, we all have it. It's neither good nor bad, it just is. It comes from our background, from our personal experience. Where it comes into play in terms of screening in particular, and a bit in terms of treatment, is that we want to make sure that we're doing our best to not make our implicit bias unconscious. We want to raise it to the level of consciousness so we can recognize it, we can figure out if that's helpful, or is it getting in the way of us providing good care for our patients. So with the pathophys of alcohol withdrawal, we have two main receptors that we're concerned with. There are GABA receptors and our glutamate. In non-alcoholics, people that don't use alcohol at all, brain likes equilibrium, right? These things are pretty much in balance with one another. With alcohol, when you ingest alcohol, so the occasional, what it really hits hard on are some of those GABA receptors. And so that's what makes our CNS depression. That's why the occasional drinker, if they drink too much, they're going to get sleepy, heart rate slows down, just the whole sort of central nervous system gets slowed down. Occasional users, it'll sort of, once alcohol backs out of the system, it's in balance again. With our habituation, these are ones that are regular users. You see the brain, again, try to make sense of it. So when alcohol's in the system all the time, it sort of loads up on the glutamate as well to try and balance it out. If we have an abrupt discontinuation of the alcohol, you think about one foot being kind of on the gas and one foot kind of being on the brakes. So what ends up happening is that the brain just gets out of whack in a hurry, right? It takes this foot off the brake at the same time it's punching that gas. So it gets out of control. So that's why we see that central nervous system dysregulation. You see the tachycardia, the hyperarousal state, all that just based on the brain can't correct quite as quickly if we abruptly take away that alcohol. So the goal with detox, again, we want those GABA receptors balanced out again. So why do we use benzos for the withdrawal? Because they hit the same receptors, right? So it binds up some of those same receptors so that we can have more of a controlled descent. We can ease them off versus just doing it all at one time and have that whole central nervous system be out of whack. I think some people have heard there's that urban legend around, the 3-day turn with alcohol. Well, there's a reason that it exists as well. When you look at the timeline for when different components of withdrawal hit, the biggest risk, again, at that first 6 to 12 hours is going to be for seizure, right? So that's why early identification of risk can be very, very helpful in terms of preventing those seizures. When we start to see, the minor withdrawals, again, they never kind of peak. It's 24 hours, they start to ease off. It's more of your hangover type symptoms. The moderate ones, a couple days, but then it still starts to go down, where you'll see, again, this really big collision of symptoms right in that middle is that right around that second to third day when you can start to see the hallucinations, delirium tremens can be a factor. You're still not out of the woods in terms of risk for seizures. And if you do develop those really kind of severe symptoms, then the withdrawal can be very, very much more elongated. So the first phase of alcohol withdrawal, the acute phase, is again full 5 or 6 hours after the last, not necessarily the last drink, but when their blood alcohol level falls below where they're habituated to, right? That's when you're going to see that anxiety, irritability, restlessness, insomnia. If they're sleeping, they can get very vivid dreams. They start to crave alcohol. It's kind of like they can feel that detox coming on. So there's a very big drive to try and seek out the alcohol. They have nausea, vomiting. You will start to see that tachycardia and the sweating and the slight tremors. As we get it to phase 2, we're talking about 15 to 30 hours. This again, that peak in terms of risk for grand mal seizures happens in that second phase, and it occurs in about 5 to 15% of patients. Typically, it's again between 6 hours and then that second day that we're really worried about, but that part can be lethal, right? And again, risk for seizure increases with any prior history of seizures because the brain is just a little bit more fragile, and we can have that kindling effect, which each detox gets a little bit worse. If they have had DTs before, we're very, very concerned then about seizures, and then how long they've been using. So if it's more of a binge pattern, we're a little bit less concerned with seizures unless they have epilepsy as well. But if it's a really sustained use pattern, they've been drinking alcohol for many, many months or years, then we're concerned much more for seizures as well. Phase 3 is about that 3 to 5 day window. And this is where it can be very difficult for staff to deal with if we are not controlling this detox well, because we see that the sensory disturbances, hallucinations, bizarre delusions, agitation, their central nervous system can get so out of whack we can see that hypothermia develop. And again, that tachycardia stays kind of persistent. So the hallucinations, again, in about 3 to 10% of patients. They're usually visual, but they can be any sensory. And the death rate, if we get to delirium tremens or if we get to into severe alcohol withdrawal phase, is between 2 and 10%. Because they usually have cardiovascular complications. They could have had seizures, metabolic issues, or like the aspiration as well. So when we're doing this presentation live, I'm going to have the proctors pause at this point, and they're going to show you a video. So I'll give them a minute to do that.